Hello, everybody. Welcome. We're just going to wait a few moments whilst our attendees join us. Sadly, we can't see you, but hopefully you can see us. Always takes a few moments. Thank you. Nice to see you, Leah. Well, I can't see you, but nice to have you here. Welcome to everybody joining us today. I'll just give people a few more seconds to join us. Welcome. It always takes a few moments, doesn't it, for Zoom to allow everybody to join. I always like to give people a minute or two. Just give people one more minute to join. Always feels like a really, really long time for us at the chairing end, but I'm conscious that for some folks it takes a little bit of extra time to get Zoom set up. Leah, we can't hear you supping your tea, don't worry. We're actually in webinar mode today, so you can hear us, I hope, but sadly we cannot see or hear from you. So please do communicate in chat, but actually we'll be using the Q&A function, which is at the bottom of your screen. It's towards the right on my screen. That's how we'll be hopefully communicating with you today. But it's 3 minutes past, so we've got quite a few members who've already joined us. So I'm going to kick us off. It's great to be here. Welcome to everybody who's joined us so far. Today we're going to be discussing how creative and community assets can speak to the NHS 10-year plan. We've got two fantastic speakers lined up for you. My name's Helen Chatterjee. I'm the Programme Director for Mobilising Community Assets to Tackle Health Inequalities, which is a partnership with the National Centre for Creative Health. And it's really nice to have you all here with us today. We've got two brilliant speakers. We've got Linda from our team at UCL, who's a Senior Research Fellow in Health Inequalities. And we've got Alex Coulter, who's the Director of the National Centre for Creative Health. We are recording today's session, so it'll be available to everybody. And what we're going to do is we're going to hear from our speakers, and there's going to be lots of times for questions. If I can remind you to post your questions in the Q&A function, which is just at the bottom of your screens, hopefully for most of you. And you can post your questions in there. And what I will do is I will then read them out, and you can either post them anonymously or you can put your name next to them. I will read them out and ask our speakers to respond to them. So I hope that sounds okay. It's nice to see you introducing yourselves in chat, but just a reminder to post questions in the Q&A function, just because then it's a little bit easier for me to be able to find them. So I hope that sounds okay. It's really lovely to have lots of you here today, and I hope you're going to enjoy yourselves. And we're going to kick off today hearing from Linda, who's going to give a bit of background on the 10-year health plan and tell us how mobilising community assets as a research programme is speaking to the 10-year health plan. So over to Linda, and enjoy your session. Thanks, Linda.
Thanks, Helen. I'll just share my screen. Okay, I hope everyone can see that now. Well, I've been looking, in fact, I've been going all the way through the 10-year health plan. And in particular, I've been looking at aspects of the plan which align with our research for mobilising community assets. So just looking at the proposals of the plan to begin with, the NHS declare themselves at the moment to be hospital-centric, detached from communities, and organised into multiple fragmented silos. They appreciate they need to provide care which is continuous, accessible, integrated and value-based. And they propose 3 radical shifts in the way that they work to achieve this, from hospital to community, analog to digital, and sickness to prevention. They have a new principle that care should happen as locally as it can. So digital by default, in a patient's home if at all possible, in a neighbourhood health centre when needed, and in a hospital if absolutely necessary. So after going through the plan, I've identified 4 aspects which align with our Mobilising Community Assets research. These are tackling health inequalities, care in the community, partnership and collaboration, and planetary health. So starting with health inequalities, they rightly identify in the plan that a person's health is shaped by the places they live in. We tend to describe this ourselves as being like a postcode lottery. And they refer to Marmot's work on the social determinants of health, which explain the country's wide and widening still health inequalities. They also agree, as we do, that the social determinants of health tend to cluster in more deprived parts of the country, such as Blackpool. And I've also taken some quotations from the plan. So, for example, they would like to end the class divide by redistribution within society. And they carry on to say that it's commissioners that will be responsible for strategic commissioning to improve population health and tackle health inequalities. They also identified that prevention is needed, so prevention rather than cure, to improve health, boost the labour market, narrow inequity, and reduce NHS costs. But they talk about prevention in 2 ways. They talk about primary prevention, which is a type of prevention that might come to mind. So this is action on tobacco, obesity, and the social determinants. But they also talk about secondary prevention, which includes genomics, predictive analytics, and AI to preempt need and risk. So moving on to the second point, care in the community. They're very keen to deliver value-based healthcare, and they do say that in the quote on the right, more care in the community is better and more efficient in terms of cost saving than care in hospitals. Though they are at great pains to in fact point out that when they talk about value-based care, they say, but they don't mean as cheap as possible. They say, but they think it should be that which represents the best value for money. And the best value for money is in out-of-hospital care, which is where they want to put their greater investment. So they plan to establish neighbourhood health centres in every community, beginning with places where health expectancy is at its lowest. So these neighbourhood health centres will be a one-stop shop for patient care, open 12 hours a day and 6 days a week, and they'll have multidisciplinary teams working in them. So this will represent a shift in investment over the next 3 to 4 years as the local areas build and expand these neighbourhood health centres. Integrated care boards will be the commissioners of local healthcare services, and the intention is that GPs will work over larger geographies and lead the new neighbourhood providers in the neighbourhood health centres. And in fact, Wes Streeting in his talk yesterday did say, but he thought GPs were perhaps best placed to do this sort of work. So partnership and collaboration is the third point. And again, this is something we would agree with, that there should be co-location of NHS, local authority, and the voluntary sector within these neighbourhood health centres. And the quote on the right supports that. And this will involve new collaborations. It might include commercial partners, universities, councils, and mayors. The intention is to trial new roles, but also adopt proven models such as peer support workers and experts by experience. Now, they plan to have a new platform for NHS volunteers because they appreciate the importance of volunteers to support neighbourhood health centres. So there's a quotation on the right to this effect, bottom right. However, they want to have their own NHS volunteers, and it isn't made clear in the plan whether these will be existing volunteers in the community or these will be people who they train up and regard separately. They also plan partnerships with libraries and community organisations, particularly to set people up on the NHS app. And because there is quite a bit still of a few issues with digital literacy and having the right sort of phone or tablet, they plan to recruit app ambassadors who will help people get started on the NHS app. So these neighbourhood health centres will bring hospital services into the communities, and these services could include post-operative care, diagnostics, and rehabilitation. But they also plan to offer things like debt advice, employment support, smoking cessation, and options for weight management. And the fourth area to come out of the plan, which aligns with our work, is that of planetary health. So the aim is for the NHS to achieve net zero by 2040. So in fact, that's 5 years beyond the 10-year plan, which runs to 2035. And it wants net zero for the emissions it can control, and another 5 years on for emissions it can influence. So all of the NHS will be expected to decarbonise, reduce environmental impact, and increase resilience to climate risk in line with the Health and Care Act, which was 2022. The NHS plans to partner with Great British Energy for solar power in all public buildings, all of their public buildings. And the government is committed to decarbonising transport systems and reducing emissions from domestic burning. The NHS want to consider private-public partnerships to deliver decarbonisation projects, such as renewable energy generation across the NHS. And there's also going to be support for active travel to reduce emissions from vehicles and support physical activity. And on the right, the two quotations which represent areas which come up quite a bit are to do with pollution, particularly air pollution, being quite bad from people who, through no fault of their own, live closer to main roads or busier areas. Hence the need to support active travel, which effectively means things like children walking in groups to school and people opting to walk rather than take a bus or a train. So although there are quite a number of key targets of the NHS, I've listed 12 here, which again relate to mobilising community assets. The first 4 in this light blue colour are those which are happening immediately from the start of this year, and they will continue for the next 10 years. So years ahead is at the bottom of the graph on the right. So as we said, establishing neighbourhood health centres in every community, but starting with those which are more in need. They want them to incorporate genomic data, and this is to do with children at birth. At the moment, I think just 10,000 of them having a test to determine things about their genetics, which will be held on file. They plan that most outpatient care will happen outside of hospitals, and they would like to achieve net zero. Then looking at the yellow bars on the graph, which will be starting next year and the year after, so 26 and 27. They want to reform the Better Care Fund. This is joint funding to services which will have integrated delivery. They want to work with the Social Partnership Forum to deliver new NHS staff standards. Some foundation trusts, and it says actually a small number, will be designated integrated health organisations. Now, in Wes Streeting's talk yesterday, he actually referred to some foundation trusts being now called advanced foundation trusts. So I think this will replace the term integrated health organisations. However, whatever they're called, these are to be operational in 2 years, and they will hold their own local healthcare budgets. They want to double the number of people within 3 years of those offered a personal health budget. And as you can see, there's around 400,000. So it's by no means, across the country. And they also want to set up the My NHS app, which is an AI-enabled tool, which will be accessed to a single patient record. So this is a record that both the patient can access and primary care and secondary care. So everyone will be able to see the same information on the one person. They want to support patients to book into urgent care services via the NHS app, or in fact, ringing 111. And going back to the personal health budget, they do in 5 years' time. So by 2030, want to make this into a universal offer for anyone who will benefit from it. I'm not quite sure how they plan to discern that, but this is what they say. So there have been a number of critiques of this plan, as you might imagine. And this is from the King's Fund, these 3 points, and I've got some more points on the next slide. So the King's Fund think that the plan leans far too heavily on technocratic solutions, AI, the NHS app, etc. And they say that there's an assumption that digital transformation alone can ease workload pressures. They think this is realistic because they think that without parallel investment in digital literacy, it's just not going to work, not going to be feasible. And they also talk about underplaying the impact of change fatigue. There have been years now of top-down reform. In fact, there was another 10-year plan just prior to COVID, which was dropped and amended 2 years into COVID. And post-COVID trauma have left staff rather skeptical. So to rebuild trust among the NHS staff requires consistent, visible leadership and meaningful staff engagement. It's not really just new policies. A lot of the staff interviewed said, just because it comes along on paper, we're suddenly expected to do it. We're not consulted. And they've become rather fatigued with this type of change. The King's Fund also think that the set of tasks to be delivered are really rather ambitious, and they say that there's a below average funding growth and fewer staff than projected. So they don't think, for various reasons, it's as achievable as it might sound on paper. Other criticisms are from, for example, London Arts and Health, and that is that there's, in fact, and I think this is where we can come in, no mention of creative health or the cultural sector at large in this plan, despite there being much evidence and lobbying from creative health and cultural practitioners. And creative health, as we all know, does need to be recognised as a key ingredient in community and preventative work, alongside other things, for example, physical activity. And then the voluntary sector have also made a couple of critical points. They're saying that there appears to be a shift from the voluntary sector and the integrated care model, notwithstanding the NHS wants to have its own volunteers. And up till now, there's been engagement between integrated care systems and voluntary alliances, and they're saying that the reduction of integrated care systems, and I think this is going to be from 42 to around 26, a number of them are in fact merging. It's only one or two that are being completely abolished. And I think this is to, again, save money. It's a cost-cutting exercise to reduce the number of administrative staff. But they're talking about it adding another further layer of disruption and risking progress made with integrated care with the voluntary system in many areas. And they also mentioned the disbandment of Health Watch England, and local Health Watch groups. And this is, it's been disbanded by the new National Director of Patient Experience in the Department of Health and Social Care. But this does raise questions about the presence of an independent patient and community voice to hold the NHS into account. So there have been a number of critiques of the plan. Anyway, so we come on to now to what Mobilising Community Assets propose, what we would like and how we can contribute to this plan. So we would like to have stronger collaboration across the community sector, which includes the voluntary sector. We'd like to have a collaborative and consortium-based approach, hence phase 3 of MCA, to community working and public health, particularly to target and serve underserved communities. We'd like community provision to be determined by the community, but appreciate that they would also need to take data into account regarding things like health conditions and health determinants, which might include social economic drivers or such as ethnicity, employability, salary and housing, etc. The community sector needs to play a key role in gathering and disseminating information about the community needs and the community voice. And this is particularly true now, given the disbandment of Health Watch. And we also advocate that all the various types of provision, this could be creative, nature-based, sports, social and legal, should be co-located and co-delivered with a view to tackling the root causes of social inequity and the social determinants of health. So we're in agreement that we're talking about person-centered treatment and prevention, and we're also talking about multiple determinants such as the social and wider determinants of health and comorbidities. But the types of co-location and collaboration we're talking about are very much wider than those currently included in the plan. And the other aspect is planetary health. This is tackling the intercepting challenges of human and environmental health. And we're suggesting that providers and services are also aware of environmental health in anything that they do to help human health. Okay, so this is the end of the talk on this, from me anyway. If you're keen to read about any of the points I've just made concerning MCA's proposals for creative health, there's 3 references on the creative health model, on community assets, and an analytic approach to the effect that they have, which is a fascinating read. And again, that's about planetary health and how practitioners put into practice care for the community as well as care for the environment. So thank you for listening.
Thanks, Linda. That was really helpful to get a run through of how the programme and that wider communities and voluntary sector can speak to the 10-year health plan. So it's really great to get that background, and nice for us to be able to launch to our audience today some of our thinking around what we think about that integration, if we're allowed to use that word still. And there's some really great comments. Thank you from many of you, Justine, Michael, about some of those challenges that perhaps present around, for example, the volunteering and what that might mean in that transactional nature, and yeah, how the neighbourhood schemes might work. So I think there's lots of thinking for us as a group of individuals and organisations who are represented today to think about how we might work together to support some of that thinking around the 10-year health plan. I don't know if that's given rise to any questions or further thoughts so far. There's no questions in the chat or in the Q&A yet. So what I'm going to do is suggest that Alex from the National Centre for Creative Health gives her presentation, and then we can open it up for a bit of a wider discussion, if that sounds all right. So over to you, Alex.
Thank you, Helen. I'll just share my screen now. So that's me, and I'm also going to talk about the 10-year health plan for England. And this is our mission. So the mission of the National Centre for Creative Health is to advance good practice and research, inform policy, promote collaboration, helping foster the conditions for creative health to be integral to health and social care and wider systems. And we are a partner on the Mobilising Community Assets research programme. So I will weave some of that information into what I talk about, but I'm going to look at our approach to informing policy and also a little bit about how we try to help foster the conditions for creative health to be integral to health and care and wider systems. So as Linda said, these are the three main shifts highlighted in the 10-year health plan. But just to rewind a little bit, you're all aware, I'm sure, that this came out of Lord Darcy's independent investigation of NHS, of the NHS in England. And I think it is worth, and it came through very much in what Linda was saying, this does come out of NHS thinking. So it is very much about the NHS, even though when they use words like community and prevention, we think of that in a much broader context. So there's something there, I think, about us bridging and understanding these different worlds and the ways people approach it. But Lord Darcy's review identified some major themes which sort of are behind these three shifts. So he said they were re-engaging staff and re-empowering patients, locking in the shift of care closer to home by hardwiring financial flows. And I think that's, you know, something we're all interested in. How does that financial flow change to enable the move from the hospital to the community, or the move to prevention from sickness? Simplifying and innovating care delivery for a neighbourhood NHS, driving productivity in hospitals, tilt towards technology, a contribution to the nation's prosperity. And that is something that's coming through very strongly as we move beyond the publication of the plan and into the various guidance and documents that are coming through now. So the latest document, which is around ICBs and their commissioning role, put quite a big emphasis on their contribution to the economy and prosperity and work. So there's a big focus on work and sickness and so on connected to work. And then reform to make the structure deliver. And his conclusion was the NHS is in critical condition, but its vital signs are strong. Very medical metaphor to use. So the 10-year plan itself was published in July 2025. And one of the things that it did, which I think came through also in what Linda was saying, was that it placed people, patients and service users at the heart of the ambition, theoretically, and states that the NHS will abolish one-size-fits-all care. So obviously that principle is very welcome to all of us working in a more community space. So these are the 3 shifts, and the full wording is from hospital to community, the neighbourhood health service designed around you, from analog to digital, power in your hands, from sickness to prevention, power to make the healthy choice. So in our policy work, as many of you know, we provide the Secretariat for the All-Party Parliamentary Group on Creative Health, which relaunched in November 2024 after the election, which brought in the Labour government. And we've done we've got a programme of 3 roundtables which link directly to those 3 shifts. So one of them was on prevention on March the 25th, and you can read a blog about that roundtable at that link. The next one is on neighbourhood health and is next Monday, but you can still sign up to watch that online if you'd like to, and the link is there. And the third roundtable will be on digital creative health in spring 2026. And we have a call out for case studies, which is live now, and the deadline is in January. So those case studies will help inform that event. So please do note down that link if that's relevant to you. So the first roundtable related to the 3 shifts was on prevention. And we had lots of speakers, and as you'll see in the blog, all the different speakers that were involved. But I've got some quotes here from some of those speakers. And obviously, Professor Michael Marmot is someone who we are really keen to engage with the creative health field. He was a commissioner on the Creative Health Review, which was published in December 23, just before the election. And he spoke at the launch of that report, and he spoke in this roundtable. And he, at the launch of the report, and to a certain extent in the roundtable, he made very clear that the social determinants of health, which, in their sort of narrowest form are essentially housing, poverty, education, access to green or access to the environment. He said that providing people with meaning and purpose in their lives was as important as food and water and shelter. And so giving people a reason to live, if you like, is also in that social determinant territory. But he has never presented evidence to suggest that creativity or access to creativity is a social determinant. But we would like to, that's where we're moving, I think, in that direction. And he certainly supports the idea of that. He just doesn't have that evidence. And David Tovey is a person who's experienced homelessness. So in a sense, that is somebody from one of those very marginalised groups who we know experience great health inequalities. And he makes a similar point from his own personal experience to Michael Marmot's views. And alongside him, Professor Monique Lucier spoke with him about homelessness, because she is the principal investigator lead for one of the Mobilising Community Assets Phase 3 programmes, which is called Making Every Community Asset Count, Improving Health and Reducing Inequalities for People Experiencing Homelessness. So they both talked about the role of creativity in supporting people who experience homelessness, and how that can be involved then to work with, or can be used then to work with the most marginalised of communities. Then you've got 2 quotes here from policymakers, so one from the Minister for Public Health and one from the Director of Public Health for the South West, Justin Varney-Bennett. And you can see in those that they both ostensibly recognise the value of creativity in the arts. In the case of Ashley Dalton, she's saying that it's an important part of our health and well-being and the future of the NHS. And in Justin Varney's quote, he's recognising the asset that the cultural sector is for people's health and well-being, and that really it's a huge opportunity for public health. So that is obviously encouraging, but as always, we want more than just words. So the roundtable on Monday on neighbourhood health has again got lots of different speakers, and I've just got a couple of illustrations here of two of those. So one of them is several people, actually, a commissioner from East Cambridgeshire South Integrated Care Partnership, an artist, Full Scope, project manager. Full Scope is a collaborative of mental health charities in that area, and children are coming. So we've got 2 primary school children coming to speak about this project. So what you see here is an image of a What Matters to Me map, one of 700 maps and creative prescriptions made by over 1,000 children. And the East Cambridgeshire Integrated Neighbourhood team wanted to hear from younger children about what matters to them, and asked Full Scope to explore that. And they worked with Cambridge Curiosity and Imagination, which is an arts organisation, who facilitated that process and delivered whole day, whole school creative activities with children to ask them that question. So I've put this one up because Cambridge Curiosity and Imagination worked with universities in the first Mobilising Community Assets phase and delivered a programme called Branching Out, Tackling Mental Health in Schools. So it's nice to see how that work has led on into something which is very, very connected in to health services. And it'll be interesting to hear what they say about what they're going to do with all that information. I know they collected a huge amount of information from all those children, and what the South East Cambridgeshire South Integrated Care Partnership is going to do with that information, and how it will inform their approach to integrated neighbourhood health. The other one I've got illustrated here is from One Weston and Woodspring. They're speaking. 2 people are speaking on that programme, and their Woodspring is one of the phase 1 neighbourhood health sites. Now, Linda referred to them as neighbourhood health centres, but I think what we're seeing from the examples we're engaging with across the country is that the idea of a health centre, which is an actual building, is not necessarily the way it's going. There may be some new buildings, and in fact we are hearing about a new neighbourhood health centre, the St George's Health and Wellbeing Hub, which is in northeast London, so there are other speakers. But I think a lot of these first wave of 43 sites are more about the place where neighbourhood health integration is happening rather than centres as such. So for the One Weston and Woodspring site, David Moss is going to speak, and he is locality lead for that area for the ICB. But he's been very involved in the Coastal Communities Mobilising Community Assets research programme, which I think they were phase 2. There was a project in Weston-super-Mare, which was about the collaboration and consortium building, and they are now part of a phase 3 programme, which includes Weston-super-Mare, Blackpool, and Hastings. I think those are 3 coastal areas that the programme, in the research programme, involves. But anyway, in the Weston-super-Mare one, David Moss has been very involved in that. It's led by Professor Lucy Selman, who's at Bristol University, and they had a day, which I was at as well, called Creative Health Board Development Day in July. And you can see there they are looking to another one of the Mobilising Community Assets research programmes, which is the South Yorkshire Creative Health Boards programme, to find a way of developing their own creative health board or network. I mean, I'm not sure a board as such would be the outcome. And this Hope Tree was produced on the day and shows a sort of summary of everyone's hopes and expectations for this process. So David Moss has been very actively involved in that. He's now the lead for one of these new neighbourhood health sites. So there's real crossover there. And this is what, is very good to see, is that sort of joining up of the dots. And in fact, the other person coming to speak at the event on Monday is someone who's had a lot of health inequality experience herself, and recently an acquired disability, but she's also a musician and uses music not only for her own well-being, and she was a professional musician, but also now leads a community music project in that site. So the fact that David's bringing her to this session again shows that join up, and she was also there on the day when they created the Hope Tree. So I think it'll be very interesting to see how many examples of creative health involved in neighbourhood health sites we find in this first phase. And the programme, these 43 sites, they aren't getting additional funds. They are actually places where it's already happening. So rather than, completely new, although they, as Linda said, they are sites where there's high deprivation and need in this first phase, but obviously it is only a first phase, and the idea is this will roll out across the country. But it is a learning program, so they're getting support around coaching and mentoring and so on. And so we're really keen that any stories about creative health integrated into these sites gets up through that learning program to national. So there's national awareness of the benefits of creative health. So the third shift is the digital. And as I said, we've got a call out for case studies. In the 10-year plan, I think you can see in the bottom point here, non-artistic digital innovations that positively impact the accessibility and measurement of creative health provision in health systems, i.e. data collection. And really, in the 10-year health plan, it's not digital as we would think of it in terms of createch. It is very, very much about data collection, although apps that provide people with creative opportunities, of which there are examples. Just a little anecdote. I heard the other day that because I was in a meeting all about createch with various people involved in it, and they were saying that social prescribers weren't using their offers. And what came back from the National Academy for Social Prescribing was that social prescribing link workers can't judge the quality of digital offers, so they rely on the NHS app, or I don't actually know much about this, but NHS Digital sort of approving apps in order to be able to prescribe them. So I think that's a key thing. How do you get the offer, the creative health offer, in this case digital offer, into a sort of NHS approved system? And maybe that's even more critical when it comes to digital offers. And we know that there's an app, and I can't think the name of it at the moment. Jane, who's in the audience, will know, an app produced by creatives in West Yorkshire that is part of the NHS offer. So it is possible, but that's working at quite a local level, not necessarily getting things into national systems. But anyway, we've got this call out, and we're very keen to hear about createch stuff that's going on, and we want people to submit case studies, and we'll use that to then inform this event in the spring. And there's the broad umbrella that would include things from as simple as getting as creative health practitioners going digital, which so many did in the pandemic, obviously, through to what's collectively referred to as XR, or extended reality, which covers virtual reality and so on, and how it's being applied in health, which is also happening. But it doesn't seem to be very integrated yet. So please circulate that call out to your networks, and I can put the link in the chat. And then very briefly, I'm not sure how long I've been going on. That's about 15 minutes. I think it's okay. Our work in systems, the Creative Health Associates programme, which was funded by Arts Council England, was delivered from July 23 to March 2025. So in fact was pre the publication of the 10-year plan. So I'm not going to talk about it in much detail, but just to say that for us, this has provided a kind of platform in which we can go forward in terms of that embedding creative health now with the knowledge of the plan and all the changes that are going on with ICBs. and the guidance that's coming out. So it's been really brilliant to have this programme under our belt, as it were, and it involves 7 creative health associates in ICBs, 1 in each of the 7 NHS regions across the country. And I've just put up this this diagram of the 2 loops model, which comes from the Berkana Institute, because this is the theoretical framework that the evaluators use to look at the impact of the work of the associates in that time period. And it's interesting from a systems change perspective, because it's giving us a language to talk about how the associates or similar posts can have an impact and change from within. And I think a lot of their work was really at the beginning of this 2 loops model. So it was about naming creative health. It was about making sure there was awareness of creative health in that system and beyond, and connecting people, encouraging networks and relationship development and so on. And then identifying the pockets of the future, identifying what are the opportunities and innovations that are coming, and providing a bridge then between the old and the new. So I think that's really critical in those roles. It is about bridging languages and mindsets. And we will be launching a future phase of this programme at the beginning of December. So that's very exciting. And the next round of associates who are now going to be called Creative Leads, the programme is called Creative Leads in Systems. They will have all of this learning that we got from that first programme to inform their work, and it will no doubt be quite focused on the 10-year plan and those priorities. So I think that's everything from me, and I will hand back to Helen.
Thank you very much, Alex. That was fantastic. Really great to hear about the work that you've already done and continuing to do to think about those alignments with the 10-year plan, and lots of synergies, I think, in terms of the work that's going on across many of the Mobilising Community Assets projects, that many of whom are represented here today. And I can see that there are we're starting to get questions in chat, so people, please do post your questions in chat. And a really important point, I'm going to read it out, Michael, that you've made about understanding, which very much speaks to what Linda and Alex were saying about understanding what we mean by NHS and what NHS means by that word neighbourhood, which is significantly larger, as Michael says, than many people would imagine. And I think that very much, and Michael's second point is that this can be a major disconnect when trying to pitch creative health solutions as part of the integrated neighbourhood model. And I think that very much speaks to your point, Alex, about how can we better articulate our offer, that creative health, that communities-led offer, to people who perhaps don't necessarily conceive of interventions or preventative strategies in the same way that we're articulating them. And this is a topic that's come up a lot, I think, for many providers around the types of activities, programmes and interventions that they're offering and how they can pitch it to get it approved by NHS. It's a very different language, it's very different costings and framings that we need to gather. And that's what a lot of our research projects within the Mobilising programme, that's exactly what they are working on. But I think it very much speaks to those points you made, Alex, about really having to think creatively about how we are working in that integrated way and what that means for a more integrated neighbourhood health offer. So I'm going to move us to our first question. Thank you to Justine, and please encourage everybody else to post your questions, or if you've got comments, please post them in chat. So Justine has said, why do you think that creative health is not gaining traction within NHS planning? Is it because they mean secondary and not primary prevention in the plan, or an assumption that it is the concern of or funded through other routes such as culture and councils? So I don't know whether Alex and then Linda wants to have a go at that.
Well, I just think we're on a very, very long journey, and it's multi-pronged. I don't think there is a simple answer to why it doesn't get in. I mean, one thing I often say that sort of really struck me is it was coming from talking to people in Dorset actually around their creative health strategy and what was going on with it, the NHS, and how it related to the offer on the ground, which is very rich and varied in terms of what's going on. And the sort of realization, a bit of a light bulb moment, that the NHS tends to plan for big goals, like, say, in this case, 50,000 people, older people will have a better quality of life. That sort of goal is clearly not deliverable just by the NHS. But what the NHS would tend to do is then measure the bits that they are doing, they are responsible for, they pay for. So if they aren't commissioning something, it's not on their radar, it doesn't get measured. So I think we're in a bit of a problematic loop there around things not being paid for by the NHS and therefore not seen by the NHS. So they're not visible to the NHS. So I think that's one of the things. And, all of us are very interested in the whole commissioning issue, the challenges to that. And I think that the NHS and other healthcare, public health and so on are moving towards a more open understanding of all of this. I do think I think things are shifting. But to see things in NHS planning, particularly central, national, is very, very challenging. I mean, obviously in the NHS plan, they did talk about physical activity, which was sort of outside NHS world. And, we might have got creative health stuff in there, but we didn't manage that. And we're constantly lobbying and advocating wherever we can and whenever we can. I personally have seen a shift in the last 6 months. I feel we're getting a more responsive reaction from DHSC itself. So, for instance, for the neighbourhood health meeting on Monday, we've got Dr. Meenal Bakai, who's the neighbourhood health lead for the Department of Health, coming to speak. Maybe it's because she's speaking, but for whatever reason, we're getting quite a few civil servants from the Department of Health or NHS, the teams that are sort of working together, the strategy teams, coming to that event. So I feel like we're seeing a bit of movement, but it's not visible in plans as such. But having said that, there are quite a lot of strategies around the country at the sort of next level down, i.e. ICS, ICB type level, or public health level, where there are creative health strategies, or creative health is in strategies. Two directors of public health strategies came out last year, Croydon, and East Sussex was the year before. I've just heard about another one that's, can't remember where the Director of Public Health is making their whole annual report about creative health, essentially. Well, I mean, I feel that's progress as well. So I think it's slow, but it is happening.
Yeah, that's really helpful. And I agree. It sounds like the kind of national level integration is often more challenging, isn't it? I guess it's so big for a start. There's that scale issue, but at that local and regional level, there does seem to be much more awareness, and certainly the learning that we're finding through mobilising, and it might be that some of our mobilising projects who are here today can share some of their learning on that front, but that buy-in at that level, integrated care board within local authorities, within statutory and non-statutory services, there is much more interest in this kind of more creative collaboration and understanding the diversity and contribution that wider communities sector can make. So, Linda, I don't know if you wanted to come in on that question at all, if you wanted to add anything else.
Well, I mean, there's very little I can add to what Alex has already said, except I think it might be just sheer budgetary concerns. So they're obviously going to have a limited amount of funding over the period of the 10 years they seem to be planning for and beyond. And I think they actually want to be seen to be spending money on what they regard as sort of medical interventions. So the limited funds seem to need to be spent on sort of preventative treatments, the state-of-the-art hospital equipment, and things which help with prevention, like various types of scanners. And they, I think, see the idea of spending money on creative or cultural interventions actually, I mean, I shouldn't use the term a waste of money. They probably don't see it like that, but don't see it as having the same importance. They're stressing the voluntary aspects, and my feeling is they think all of that somehow can come out of the sort of voluntary or community sector. But I think Alex has given a very detailed account. So
Yeah, I mean,
very little.
that does speak to what we know certainly in the past has been a barrier, isn't it, around the quality of the evidence base for non-clinical community-based interventions and preventions, which is often held up to the same standards as a clinical intervention, where we know from a research perspective it's almost impossible to get that level of causal effect that many commissioners might be looking for. But as Alex says, I think there is hope and optimism, isn't there, as commissioners and providers start to have some convergence on a shared language. And I guess that's what we're really keen within the Mobilising programme, is to work towards that learning around how could we bridge that gap so it is easier for commissioners to be able to understand what those offers are, how they can be effectively implemented and measured, and ideally funded, so that in answer to Justine's question, yeah, it's not just the standard routes, like Linda says, the voluntary sector or local authorities, Arts Council and other types of funders. So thanks for that question, Justine. I'm going to move us on to Michael's question, who has asked, do you feel that creativity is particularly overlooked, or is there a general lack of focus on determinants of health in the 10-year plan? Really good question. I don't know who wants to pick that up.
Yeah, I mean, Linda, do you want to respond to that?
Well, I suppose that's a sort of almost like a correct assumption. I mean, I was actually quite surprised when I read the 10-year plan that they had covered in depth the social determinants of health and referred to Marmot on several occasions, Michael Marmot, and you know, were aware of wider determinants. And as with the previous question, I think they perhaps haven't got round to thinking about the importance of creativity. So the social determinants of health have been with us for quite a while. People have been aware of them, and you can understand why those have actually been included. But I think there's been less emphasis on the use of creativity and cultural aspects within health. I mean, a lot of people I've talked to have identified that these things only came about during COVID. Now, I know that's not the case. I know creative health practices were well before COVID, but most people saw it, that it was something to do during COVID, which was helpful if people were feeling lonely or isolated, or they wanted a digital link with other people doing an arts activity or singing in a choir or something of that sort. So looking at it like that, a lot of the identity of creative health, though of course we know it's been very much longer, for most people seem to have originated in the last sort of 5 years or so, whereas obviously Sir Michael's been writing about social determinants, as have others, for 10, 15 years or more. So it may simply be that creative health is taking longer to work its way, if you like, into the psyche of the NHS. Do you have anything to add to that, Alex?
Well, I think you've made an interesting point. I think public awareness, the people, is a sort of gap in our efforts generally, and it's not because it's because it's quite difficult to reach that level of communication. But I think that it is part of the reason why it's not so familiar in NHS is because people aren't that aware of it. And I think you're right that COVID it's making that link. It's making the link between health and creative access or creativity that the public has begun to do perhaps because of COVID. But making that link at a public level, i.e. communications, public messaging and so on, is not, no one's been able to do that, unlike say sport, where sport has been linked to health in the public imagination. I don't think culture and creativity has been, and that's something which I think we have to do collectively one way or another over the next few years, because it will be a demand and supply thing. You know, we do need to increase awareness and therefore demand, certainly. So I think, yeah, I think that is the reason why perhaps it's not very visible or thought about in terms of health.
I mean, I wonder if just as an extension to Michael's question, just thinking about the main driver of, the main facet behind Michael Monmouth's work and all inequalities work is around poverty being the main driver, lack of access, socioeconomic drivers, unemployment, lack of access to quality housing, legal advice, welfare advice. And of course, those are areas that the NHS per se, an NHS trust, a hospital, primary care, they can't solve. And so I wonder if there is a sort of a question back to everybody really is, I wonder if that is part of the challenge. In a way, I think many of our projects working closely with people like Citizens Advice Bureau, and when you talk to colleagues in those sorts of services, they say the same thing really that we're saying in the creative sector, which is getting your offer out there is very, very challenging, because it seems like you're competing with all of these other offers of, quality housing or access to nature or physical activity. And I wonder if that could bring us on really to thinking about our next question, which is really good, which is from Kelly. And Kelly says, you mentioned collaboration and co-location with other types of health provision, nature, physical activity, etc. How do you see that working in practice? It seems like you have enough on your hands to lobby for creative health, but equally, if all these strands come together, there is a louder and larger voice, which I think is very much what we would agree with, Kelly. So I don't know, I've got some thoughts on that, but I don't know if Linda, Alex, you want to come in on that point?
Yeah, I think that I don't think it's either or really. And I think that we all put our efforts into the bit of all of this that, we feel we've got the expertise perhaps or the capacity to do. And we definitely do need to be, for all the reasons we've just been talking about, lobbying and raising awareness around the role of creativity, cultural assets, as much as their relationship to those broader community assets. I have to say I'm not sure about co-location. To me, that suggests again a place, physical place, which may or may not be the best way of delivering integrated care. I think that sort of integration with nature, physical activity and so on is very much social prescribing territory, but social prescribing obviously doesn't necessarily cover prevention and community offers that are, if you like, pre-referral. So I do think that the sort of place-based approach is really important, and in a place, to what extent cultural and creative organisations are linked up is very variable. And I think where they are linked up with other services and other, with nature and all the rest of it, that can be very positive for everyone. But you require the kind of mechanisms and the motivations, the incentives for that collaboration to work. I mean, the Thriving Communities programme, you may remember, which was a NASP project delivered by Arts Council, was, I think, very effective at that. I remember hearing quite a few creatives talking about the benefits of having worked with colleagues in physical activity and nature and so on. So, but, they can't necessarily just do it. You need incentives and mechanisms to support that. So, yeah, I think it's complex, but yeah.
And funding, Alex. Linda.
I was just going to say, I don't necessarily see such a distinction, though, between creative activities and activities in nature. I mean, some of the activities that we've had the privilege to look at or work with have tended to use sort of both. So we've looked at art projects where children might be in woodlands, forests, outdoors in nature, and they've been doing art projects. So there are various ways in which art and creativity is incorporated into the natural world. So there's not such a distinction as creativity taking part in one place, and then nature and natural green activities, green social prescribing taking place somewhere else, like outside. I think there is a huge overlap between the two. And I've also talked to a number of people who have been running very creative activities within green spaces who say, well, in a way, we were social prescribing before social prescribing came along. And, you know, it's just whatever people happen to want to call it, which isn't strictly the case because, of course, social prescribing does involve or should involve more of a formal referral. But there is quite a great deal of creativity when you think about it in gardening, for example, growing things, growing plants. Even if you're not formally doing some sort of artistic endeavor within a natural environment, there is also sort of the creative thought processes about how you would like, if you're working on a garden or a park, how you would like to see that in the future, how you envisage that the growing plants, trees, etc. might look. So I think I don't see it as a sharp distinction, and I would like to see more integration of creative and green interventions. However, I do take the point that yes, it is, you know, something else, it's another aspect, and there may well be lots of other aspects that you know, haven't come to mind, but would be beneficial.
Yeah, thanks for that. No, that I think makes a really good point as well. How, again, going back to that idea of how we articulate and sell creative health is that we often focus on those kind of creative aspects, and they're of course really important, but there's often many other aspects, that cognitive aspect of being critically thinking, and that often there's lots of evidence now that shows around that sort of agency you're talking about, how that can be helpful in people then tackling those social determinants. So the creative activity might be a conduit for them to tackle those more social aspects of their health. And of course the physical, we often forget about the physical engagement in all of those sorts of activities. Obviously, if they're outdoors, it's obvious where the physical engagement is, but even things like hand-eye coordination tasks, precision grip, they can be really, really important for improving physical aspects of health. And there's some really great research going on about that. And just in terms of that co-location idea, I guess we're really big proponents of it because we've seen so many of the projects under Mobilising who are working in that space, and we've got some really great example. The Coastal Communities and Creative Health Project that Alex mentioned, that's based in Blackpool, Weston-super-Mare, Hastings. Up in Blackpool, they have a great organisation called The Grange, where it really is co-locating so much different kind of community-based activity, a library, a theatre, a cafe, community-led cafe, a garden project, but they also have different members of the council team. They have a warm hub space, they have a washing machine space so you can go and do free washing. They have like the energy advisors going in, the mental health team go in. So it's really that, and again, they're finding that a lot of the more creative activities or the gardening activities are often ways to get communities who perhaps might not be necessarily engaged in those services better engaged in that provision, and to understand what services and facilities are available to them in the communities. So we're really keen to collect examples of those. So if anybody has other examples of that kind of co-location, we'd love to hear about it. I'm going to move us on and a comment from Justine, which I don't know if you guys want to comment on, which is Justine says, maybe it is down to us to integrate our offer more at a local level and increase the scale and impact of the offer. So a really important point there about scalability. So I don't know if anybody wants to come in on that point.
Yeah, and just to say, Justine's also put some interesting stuff in the chat about medium-term plan and how money is going to be shifted to prevention, but there's still this sense, several people maybe have said this, that the focus is still on the acute issues of hospital admissions and so on. And we're hearing that a lot in relation to the neighbourhood health developments, that there's still this central focus on trying to sort out the problems, the very immediate problems of waiting lists even though we all know that it's all connected, it still makes it very difficult for money to flow to prevention. And, you know, do read the new commissioning guidance that's come out for ICBs. It again talks to shifting money, decommissioning things, being innovative, you know, developing partnerships and so on. So they're all talking about it, but we know that the reality is that on the ground it's very difficult. So yes, I mean, anyone who's working on the ground, keep going is all I would say, and do integrate at a local level and tell other people about it. I think that we're here, organisations like ours are here to feed that information up through the food chain and try and show how it works. But yeah, scalability. I mean, I often think spread is a better word than scale, because I feel like it's about lighting fires and letting things organically develop and spread. But you know, maybe that's just semiotics. Semiotics, semantics, anyway, whatever, you know what I mean, language. But yes, I think everyone has to keep going and support each other, because it's not easy.
Yeah, and like you said, there's a lot of great points in the chat about that. Michael, again, really helpful, talking about his experiences within the ICB. Of course, that those services are just overwhelmed by things like, yeah, emergency response, A&E, and waiting lists. So it's that idea of, yeah, supporting those rather than competing with. And Michael's made an important point about creative health supporting a waiting well, which is, yeah, really important. Again, I wonder if this speaks to how we are articulating the offer and those things that we can speak to. Earlier on, Alex, you'd mentioned about productivity and a lot of links essentially being made. One could be skeptical about that, but to do with basically the huge cost of the NHS and health generally, and the burden that causes, versus then the huge cost, for example, around sick leave and what that costs, and that really affects economic growth and productivity. So again, if we can articulate offers in the sense of keeping people healthy, keeping them, you know, in work, and those are the sorts of variables that we don't collect when we're measuring the impact of creative health activities. But maybe we should be thinking more creatively about what kinds of evidence we're collecting and how we're collecting it, and how that affects things like return to work, or keeping people in work, or access to volunteering, and the implications that that can have. I'm just going to take us back to our Q&A list. So Maddie has said, I'm somebody who works in a health centre. Hello, Maddie. Nice to see you, or hear from you, rather. Maddie's working in a health centre that has a GP practice and has recently had a co-located integrated neighbourhood team come into the building. I find that we are already running on maximum capacity and have little space for new participants. I fear that a bottleneck might start to happen where we get too many referrals. Do we have any ideas on how we can sustain structures in these NHS systems on charity funds that they don't get any NHS funding? And just to let you know that Maddie has helped establish something called Creative Health Camden, which is in Kentish Town Health Centre. So that's a really important question, that you're almost a victim of your own success, Maddie, at Kentish Town Health Centre becoming Creative Health Camden. And yeah, I don't know if anybody's got any thoughts on that. That's addressing directly that issue of scale, but of course it comes with that issue of funding and sustainable funding, and amplifying that funding to hit more people.
I mean, I'd be interested to know why exactly there is no NHS funding in that locality. If you're, you know, I think we need to better understand, again, the mechanisms. We're trying to understand commissioning and talking to lots of people about that, and we'll be doing an event in March to really explore that a bit more deeply. But what exactly is going on in your local patch, Maddie? Why are those conversations not happening? What are the barriers, I suppose, to getting some NHS money or health money, or not charitable money, into the work? You know, I'd just like to know more detail about what's going on there. So maybe you could email me about it.
Well, and actually, Maddie and Jane and I, for those of you that don't know, Jane Hurston and the mobilising team and I have been working with various integrated care systems, most recently Gloucestershire ICB, and as you may know, Gloucestershire has a very well embedded creative health sector, and they have a creative health consortium who they fund directly, they commission directly. So we've been understanding how has that relationship evolved, how is it sustained, how is it funded, and it is very connected to, it's a very data-driven approach, and it in fact forms the topic of our next webinar, which I think is on the 11th of December, but we'll put a link to the chat in the chat to that. But that kind of learning about where you can see that adoption and that level of commissioning directly into creative health organisations, we're really interested in that. So we're very keen to work with you, Maddie, on the work that you've done in setting up Creative Health Camden and learn, I guess, what we can from other systems. Yeah, exactly as Alex says, we're very focused on those barriers and enablers. What's working really well with you, Maddie, I can see, being a Camden resident, is the range of services and activities that you're linked into and the communities that you're working with. But like I said, I think you are a victim of your own success. And I guess it's understanding, yeah, like Alex says, where that funding is going and where it's not going, and what additional types of funding you need and where that ought to come from. And what that kind of lobbying, you know, it's taken Gloucestershire, for example, you know, it took 10 years to embed their model. It wasn't an overnight process. And I'm sure other ICBs are hoping it could be quicker, but there are obviously routes to unlocking some of that cash. Maybe not huge amounts of it, and it's never going to be the only cash, but there are obviously some routes to it. So we're keen to learn about those. And Maddie, you can always post some extra information in the chat if you would like to. And thank you. Melise, our coordinator, has posted in the chat the Eventbrite link to our next webinar. That's a good plug, where we're going to hear and share all about that learning that we found from Gloucestershire ICB about how they've integrated creative health into their commissioning model. I'm just going to go back to questions to see if there are any more. There are no other direct questions in the Q&A or that I can see in the chat. I was really interested in the exchange between Rachel and Michael. I think there's a lot of really interesting points there about those crossovers. I've always been a huge advocate of that, having less of these silos and ways of thinking about, we've got creativity, we've got physical activity, we've got sport, we've got nature, and they're often considered very separate. I really liked your point, Michael, that providing an emotional, regulating and socially connecting activity that becomes a self-generating support mechanism. I think that's a really important point. And just in that articulation that you've made, there is a very different way for us to articulate how a creative health intervention might bring about benefits. So I think that's really important learning for us. I'd be really keen for us to continue those conversations, because it very much speaks to this idea of the kind of one health approach, planetary health approach, how we're connecting up the care of the environment and the care of people. And a lot of systems and services are starting to be asked to think about that. And even the government departments, where they then have some crossover themes about, for example, as Linda says, how NHS is meeting net zero. So again, it does help us to be able to, I think, articulate in that sort of language. I just wanted to keep my eye on chat and Q&A. I can't see any of the questions. If anybody does have any final questions. Michael says, keep your eyes peeled for the Northumberland. Oh, it's popped down my screen. Hang on. Creatively Healthy Communities Framework, which talks about this. Oh, great. Hopefully approved for publication next week. Loving your shameless plug. Please send that to us, Michael. It sounds really, really interesting. And we're continuing to do our work in this space with many of our Mobilising Community Assets projects. So we'd really love to hear other learning that can feed into that. And I personally think there is a lot of benefit to that kind of collective action thinking. So many of the people that we work quite closely with, Natural England, obviously NCCH and NASP, are also thinking about these areas. I think there is a lot of interest in that kind of connectivity. So be really keen to have those chats further. Lots of other points in chat, so thank you. Justine has made a point about, yes, the Gloucestershire model, and absolutely, and we're not necessarily saying, Justine has made a point for those that can't access it, in terms of the Gloucestershire model, which has its merits, but also not perfect. And absolutely, and I think many of those providers might agree, in terms of a lot of what has driven it is that data linkage between the participation data, health outcomes related to participation, and then linking that data up with the kind of standard population health data that population health people hold within the ICBs or within population health teams. And that has helped to drive investment, but that kind of data collection is very, very burdensome for the providers. And of course, it's a small consortium, as Justine points out. It's only a very small number of organisations. There's lots of other organisations out there who are doing brilliant arts, nature and community-based work in Gloucestershire who are not included in that consortium. So I think it's a really good point. I think what we're interested in is that data-driven approach, because as Michael had made the point, there's a lot of emphasis on things like NHS waiting times, A&E admissions, and I think that idea of speaking to prevention can really help us. If we can't directly say that we're contributing to reducing A&E admissions, we can perhaps downstream be discussing what kinds of activities and preventions can help keep people away from those sorts of services for longer. I like your term, holistic health improvement through emotionally regulating habits. I'm not sure it'll catch on across the whole of the creative health community, Michael, but thank you for sharing that, and we'd be really keen to keep those conversations going. So I wanted to give the last words, Linda, Alex, if there's anything else you wanted to add or comments you wanted to make.
Well, I'd just say that obviously the 10-year health plan was, everyone was waiting for it, and we all sort of pored over it to see whether we were in it, what the potential was, and so on. But as someone said, really policies, where was it? Somebody said that policies don't do it. It's actually what we do on the ground that really matters. So, and it is constantly shifting, and I think we have to learn to sort of actually value that constant churn, because it is a kind of creative space. It's not all fixed and top down, and all the things that keep coming out, is getting more nuanced. I suppose I'd just say it's really interesting to know what people are achieving on the ground, all the barriers they're experiencing, because it helps us to understand that nuance and work collectively, more collectively.
Thank you, Alex. Linda.
Well, just to say, I think the 10-year plan was intended to be a very broad document. And looking at the bar chart that I did with the 3 colours on, you could see from the 2 colours that weren't the turquoise at the top of aspects starting immediately, that there would be several years before quite a number of the intended aspects came to fruition. So I think within that time, there's quite a lot of the possibility of sort of fleshing some of the areas out a lot more through lobbying and through offers of various sorts to do with creative health. And I think there is time there. So my feeling is that it was really just a sort of, for want of a better medical term, a sort of skeleton document, which then, we could flesh out as time went on. So I think that's the way we have to regard it, because, as I say, quite a number of the aspects are going to take some years to come into practice, and it gives us quite a bit of time to work on those areas and modify them as we think, if that's something that's achievable.
Brilliant. Thank you. Well, a huge thank you to Linda and to Alex, and to all of you for all your comments, contributions, ideas. Please keep the conversations going. Join us at our next webinar. And Melissa's put our contact details in the chat, and you've got links there to the NCCH activities that are coming up too. So I hope you found today useful. Thank you for taking the time for joining us, and see you at our next event. Bye, everybody.